Listen, we're trying to get past the, mild diffuse sinus disease impression done. We're gonna sort of get past that and get to a lot more details this morning on that. So we're gonna describe the role of the radiologist in evaluation of sinus CT, critical evaluation of the sinus CT with critical anatomic variance. That's really what I want you to take home from today. Critical anatomic variance. And I'm gonna talk a little bit about structured reporting. Okay. So what is the role of the ENT? Really, the role of the ENT is to establish a definitive diagnosis of chronic sinusitis. So this is symptoms lasting greater than 12 weeks. They want to ensure that the patients have exhausted non-surgical options for treatment. So they're going to treat, and ultimately they're going to probably get a sinus CT to see if there's any anatomical reason that they might need to operate. Okay. So, in terms of this, headache and sinus pressure may be less responsive to endoscopic sinus surgery. So looking for other reasons for headache and sinus pressure. Things like migraine. 50% of patients with migraines are misdiagnosed as having sinus headaches. So you don't want to operate on a migrainous patient, right? Because it's mimicking sinus disease. So what's our role? So our role is to assess the location and the extent of sinus opacification. I use this classification system, guys. It's called the Lund-Mackay system. Now, this Lund-Mackay system is a very old system in the ENT literature. So they literally use this for all their studies. I just go with what they go with, and it's very simple, okay? So I'll show you that system in a sec here. And obviously, other ways are very common. Everybody has their own way to describe sinuses. What else do we have to do? Describe the patency of the sinus drainage pathways. And these are called the anatomic tight spots, right? There's three of them. The frontal sinus drainage, the OMC, and sphenoethmoidal recess. And we'll go through all those three anatomic tight spots. If you can really look for those, that's important, okay? So again, identify extension as well. So what are the complications of sinus disease potentially? Wayne just showed you some amazing cases of how sinus disease can go awry all over the head and neck, right? So things like the brain, the neck, the orbits, they can all involve that stuff. And this is one of the more important things we're going to talk about, and that's looking for the mimics of sinus disease, things like tumors and cephaloceles, right? That thing in the nose may not be just a mucus retention cyst, right? That's coming from above, and you just biopsied a piece of brain. You don't really want to do that. That's a poor form to see brain on the slide, the past slide. So again, so describe anatomic and critical variance, close proximity to the intraorbital and intracranial compartments, and we're going to help to avoid major complications for sinus surgery. Okay, if we can help the ENT surgeon say, hey, this artery is literally going through the sinus, that's an important thing for that person to be aware of. So what are the three most common complications? Hemorrhage by far for a sinus surgeon is the most common complication. And that's because they failed to recognize an artery traversing the sinus. I'm going to show you which artery that is later on in the talk. Clearly, CSF leaks can be complications for sinus surgeons, orbital hematomas for similar reasons. So listen, how have we done as a group of radiologists for sinus CTs? 22% of ENTs are dissatisfied with reporting right now. 67 would like more clinically useful information. And all predefined sinus CT items are inconsistently reported. These are the most inconsistently reported items on a sinus CT, guys. So I want you to think now, are you reporting any of these things in your sinus CTs? Or are we just saying, mild sinus opacification and calling it a day? Those are the most underreported and clinically useful things for sinus CTs. I'm going to go through all of those, and that was the paper that talked about that in 2013. So what can we do? We can give definitely more consistent communication and feedback with our colleagues. I cater my reports a little bit to PCPs versus sinus surgeons. I clearly get into a lot more detail with my sinus surgery colleagues, and we're going to make clinically relevant structured reports. We don't want to be this person in the reading room, like, stay away from me, I don't want to talk to you, let's be happy, bright, smiling, and engage with our colleagues. How many people have cone beam CT in their practices? Anybody? Okay, none. So this is a very common thing for dental practices and oral surgery. They have them in their office, they're cheap, and they have much lower radiation. So we see a lot of cone beam CT, especially with our dental patients. So cone beam, just to run through, because none of you are really looking at this stuff anyway, but it's got exquisite bone detail. The dose is much lower and very compact size, so people have them in their offices. Like I said, dentists, oral surgeons, facial OMFS. Poor soft tissue contrast, higher noise, things like that. So multi-detector CT, much better soft tissue contrast in that way, right? But again, the dose is higher, the bone detail is not as good. So that's a little bit about dose. Because you guys aren't looking at that stuff, we'll just move on. But just to know that the dose for cone beam is much lower. There was this idea that cone beam, you were limited because the soft tissue contrast was so poor and you're missing little squamous cell carcinomas throughout the head and neck. The Pittsburgh group came out with a paper here in laryngoscope. They said the soft tissue stuff wasn't as big of a deal as people made it out to be. You could diagnose most of it on cone beam CT, but okay, so let's get into the heart of it here. I'm hoping that you guys are looking at the sinuses in all three planes. I mean, just to look at the axials, you're not doing your sinus CTs justice at all, because some of the drainage pathways are almost invariably better seen on coronal and sagittal reformats. So you want to get thin cuts and you want to look at your stuff in all three planes, guys, to do that CT justice, okay? It is, in fact, not possible to fully assess the anatomy without referencing to the reformatted images. So you should be definitely doing coronals and sagittals. So, and the reason why is because you're going to see certain anatomy on these reformats that actually are the culprit for failed sinus surgery, okay? There may be only certain types of anatomy that you can see on a sagittal and the patient failed sinus surgery. There may be only certain types of things on the coronal that you missed or didn't identify, and that's why they failed the first step of sinus surgery, which is usually a FES, endoscopical sinus surgery. So a functional endoscopic sinus surgery. So important findings: extent of sinus bifurcation, 3 tight spots, anatomic and critical variants. So this is the Lund-Mackay grading system, guys, and your reports can reflect this. So my template is each sinus, right and left. So frontal sinus, right, left, anterior ethmoids, right, left, posterior ethmoids, right, left, and I go down like that. So frontal, anterior ethmoid, maxillary, posterior ethmoid, sphenoidal, and the OMC. There's literally 3 things you need to say about each sinus. It's either normal, it's partially opacified, or totally opacified. That's it, right? So I go through all these things, and in my dictation, I'll say, next field 1, next field 2, next field 1, next field 2, and it just says normal, partially, total, right? I try to make it pretty quick. And then the OMC, it's either occluded or not occluded. Sometimes I'll throw narrowed in there, but really that's the only thing you need to say. And this is what all the ENTs, that's all they need. The one caveat here, guys, is, you can have circumferential mucosal thickening of a lot of sinuses, and I'll mention that. If it's polypoidal, you want to mention that. If it's polypoidal mucosal thickening, because now you're leaning towards one of the most common diagnoses, which is sinonasal polyposis for ENTs and sinus surgeons. So if it's just nice linear mucosal thickening, I'll just say circumferential. If you're starting to see polypoidal stuff, that's worth mentioning as an extra little morsel for them, because that makes a difference, okay? So don't worry about the points. These are some papers. I think you have these slides, right? I'm hoping you do. I think they're being provided. So the QR codes are on there for all the papers. Okay, if you're like really struggling to sleep one night and you want to, this is a good one. You'll be asleep in seconds. Okay, so another one if you're struggling to get to bed at night. But this is some of the validations, the original Lund-Mackay system, and some of the validation studies that have been done for the Lund-Mackay grading system. So let's talk about the anatomic tight spots. There's 3 of these. And again, the OMC, it's pretty easy. So okay, great. So you can see the pointer here. Middle turbinate, inferior turbinate, and this little piece of bone right here is the unsnit process, and you can see the frontal sinus drainage pathway. And again, this is almost invariably best seen on the coronal, guys. So you want to be able to evaluate this tiny channel here on your coronals. That's the frontal sinus drainage, okay? Look at, and honestly, on the sagittal, these are beautifully depicted on the sagittal. Here's your frontal sinus, this is the frontal beak, and this is the frontal sinus drainage pathway. The anterior margin of this is something called agar-nazi. It's the anterior most ethmoid air cell is given the name agar-nazi. I'm going to show you some variants of agar-nazi that can cause obstruction of the drainage pathway, but you would never know that unless you looked on the sagittal. Those are impossible to see on the axials, right? Now, this thing is called the ethmoid bulla. It's the posterior margin of the frontal sinus drainage pathway. Again, beautifully depicted on your sagittal imaging. You would never know there are problematic variants unless you looked on your sagittal for that, right? And by the way, this is why people fail FES. For a FES, functional endoscopic sinus surgery, they're opening up the osteomeatal complex. They don't really mess with the frontal sinus at all on the initial FES. If the patient continues to have symptoms, guys, they get what they call a RES. This is revision endoscopic sinus surgery because they failed the FES. Invariably, it has something to do with the frontal sinuses or posterior ethmoids because they don't mess with those on the original surgery, okay? So again, middle turbinate, inferior turbinate there. Some more anatomy here. This is the maxillary ostium, the ethmoid infundibulum, uncinate process, hiatus semilunaris, middle meatus. This is the ethmoid bulla that we saw was the posterior wall of the frontal sinus drainage pathway. That's the ethmoid bulla right there, bulla ethmoidalis, okay? So as we know, the maxillary sinus drains into the middle meatus, the frontal sinus drains into the middle meatus, and the anterior ethmoids drain into the middle meatus, all three of those into the middle meatus. The inferior meatus takes what? The nasolacrimal duct. This is why you sniffle when you cry, right? Because the nasolacrimal duct is draining into the inferior meatus. The superior meatus takes the posterior ethmoids and the sphenoid sinus, okay? Here's that sphenoethmoidal recess. This is best seen on your axial images. So this is the one thing that you're going to really be able to appreciate. This tiny little ostia right there, okay? This is much harder to see on the sagittal, okay? But the other stuff is much better seen. So I'm going to get into this paper. If there's one paper you should read from this talk, it is this paper. It's called The Close. It was published in Radiology back in 2016. This will tell you every critical anatomic variant that should be in your sinus template. This is the one paper you should read when you are alert. This is not the put you to bed paper. This is a wake up paper, okay? And your report's going to reflect that. So this is literally the Lund-Mackay grading system, guys. Clear, partial, complete. That's to your frontal sinus. Anterior ethmoids, clear, partial, complete. Next. Maxillary, clear, partial, complete. I can get my 11-year-old to do this, probably. Or maybe I should, in fact. I'm just thinking of that now. So clear, partial, complete. Okay? Boom, boom, boom. Clear, partial, complete. That's all you need to do. Extent of the osteomeatal complex, remember, it's either patent or occluded. Sometimes I'll throw narrowed in there if I think it might be helpful, okay? And always dictate signs of chronic sinus disease. You know, you have this sclerotic wall, hyperostosis. Sometimes you'll get these, dystrophic calcifications along. These are all signs of chronic sinus disease. That's important to throw into your ENT surgeons too in the dictation there, if you have signs of chronic disease. Now, I do want to mention a couple things about acute sinus disease. There is almost no imaging correlate for acute sinusitis, okay? It's a clinical diagnosis. I know a lot of people love air fluid levels. A lot of people love bubbly secretions or pneumatized secretions. There was a paper which I didn't put here done several years ago. They scanned people in ENT offices, everybody who's presenting with sinus symptoms, and all these people had air fluid levels. They did not treat them, and they scanned them 2 weeks later, and all air fluid levels were gone. Okay? So do not hang your hat on, oh, the patient's got an air fluid level. That's acute sinusitis. That is going to be invariably a clinical diagnosis then. Okay, pneumatized secretions help. That just means they sneezed and they injected some air into those secretions into their sinuses potentially, okay? I'm not saying it couldn't be, but it's definitely not a slam dunk from imaging side. So be careful with that acute sinusitis diagnosis just because you see an air fluid level in the sinus. The majority of patients, that goes away, not treated. It'll go away, okay? Okay, so let's look at our anatomic tight spots. We talked about the frontal sinus drainage pathway a little bit. It's got this nice, beautiful hourglass configuration, the frontal ostium at the level of the frontal beak. And depending on certain anatomy, it can drain into the middle meatus or not. And I want you to visualize this, guys. That sagittal image I showed you, it can be affected by the ethmoid bulla, the size of the frontal beak, and the uncinate process. So let's just look at some of this stuff. Remember that sagittal I showed you guys? I want you to visualize that. I told you agar was the anteriormost ethmoid air cell. That was the anterior margin of the frontal recess. Any anatomic variant can cause problems. That posterior margin was the ethmoid bulla. Any anatomic variant can cause problems there. So let me show you a couple of examples of this stuff. Here's a normal agar. Look how big that thing is. This could just a little bit of mucosal thickening, and this can cause drainage problems. But I dictate large agar cells, okay? If you have a cell on top of agar that's called a super agar cell. This bony protrusion here is called the frontal beak. If this cell goes above the frontal beak, now you have a super agar frontal cell. I know now this is where I start looking like, oh my God, this guy is driving me nuts all of a sudden. Okay, I know this is the point where it happens here. Okay, so forget what it's called. Just know that this exists. Okay, because I'm going to get into a little bit more important. Just know that you look at the agar on the sagittal, and variants of that can cause frontal sinus drainage pathway problems. And posterior can also cause problems. So all I want you guys to see is that beautiful drainage on the sagittal. And, okay? So the role of the Uncinate process. We looked at the Uncinate process on the coronal. Variants of that can cause problems, and I'm going to show you how. It inserts in various parts along the way, but let me just get to these variants. So look at this, guys. This is the things I want you to notice on your coronals, okay? You're going to notice some things right away. This is the Uncinate process, right? This is pneumatized. Look at this pneumatized Uncinate process. This can start narrowing your ethmoid infundibulum depending on how big that can get. Deviated septum, big variance here. Middle concha bullosa. You guys are familiar with that anatomic variant. Now, here's the Uncinate process on this side. See that? How beautiful that is? Drainage is good. This Uncinate process is literally caked up against the orbit. You can imagine, look what the toll it has taken on this maxillary sinus. That's the problem. It's called an atelectatic Uncinate process, and this is what happens because of it. So if you can appreciate the fact that the Uncinate process is caked up against the orbit, you've done something there in your evaluation of sinus CT. Always look for a reason, right? Go through that and look for a reason. We talked about the anatomy of the osteomeatal complex, right? Again, ostium, ethmoid infundibulum, hiatus semilunaris, middle meatus. Let's talk about what can narrow that drainage pathway now. You guys are familiar with Haller cells, right? Haller cells you want to dictate because look at the narrowing and look at the obstruction you see here. So always dictate how, again, best seen on the coronal. If you guys are not looking at reformats, you're not going to see any of this stuff. So that Haller cell can be a real problem. Big concha bullosa, pneumatized middle turbinates. Imagine how this can get so big that it pushes your Uncinate process to occlude your ethmoid infundibulum. On the other side, too, it can get big. That middle turbinate is attached by the basal lamella here. That can be pneumatized. Similar things. So these are pneumatized. We call these lamellar concha. Paradoxical curvature. Is anybody dictating paradoxical curvature of the middle turbs? No one? Oh, God. Okay, please do that. Because it's supposed to curly Q out like this. If it goes like this, it can push this. Depending on how big that paradoxical curvature is, it can push your Uncinate process to close your OMU. Okay? And this is a large ethmoid bulla. Again, the toll that it takes on that OMU. Okay? All seen on your coronals, guys. Okay? Deviated nasal septums can wreak havoc. Okay? Dictate the direction of the deviation, any large septal spurs. I will give you one little tidbit, and this is a little controversial, but many people describe what they call septal contact points. If you have large septal spurs that are pushing and deforming turbinates, sometimes it's the middle, sometimes it's inferior, these things get so big they sometimes reach your lateral nasal wall. They're so big. There's an idea called rhinogenic cephalgia, guys. There are papers out there in which people have unremitting headaches. They actually correct the nasal septum and the headaches go away. It's called rhinogenic cephalgia. They'll take down the septal spur and they'll correct the curvature of the nasal septum, and the headaches go away. So I actually look for this stuff when I get any patient presenting with headache. Believe it or not, I actually look at the nasal septum as part of my checklist because they may have rhinogenic cephalgia that went undiagnosed. It's a little bit controversial in the literature for ENT, but it is something that exists. So sometimes people, in fact, my last ENT surgeon wanted me to dictate all septal contact points on every sinus CT. Okay. By the way, he made the most money at the hospital. Just so you know. Literally the highest grossing doctor at the hospital. And I never got a cut of any of that. So for all of my dictation of septal contact points. Okay, so this is like the crux of this. I want to go through this close acronym. I literally, guys, in my template, I have this acronym in my sinus template. So I know that I'm dictating everything that's important, every critical anatomic variant for my sinus CTs. Okay? So cribriform plate is the first one. If there's any dehiscence of the cribriform plate, are the cribriform plates, so by the way, that's not a nasal polyp, right? That's an encephalocele. So you want to look at your cribriform plates very, very carefully because of that, okay? Are your cribriform plates symmetric? Sometimes one is much higher than the other. You can imagine if you're a sinus surgeon going in and you assume that they're symmetric and you take a turn, now you're in brain, right? If they're not symmetric. So make sure you're dictating whether they're symmetric or not. And then everybody sort of is somewhat familiar with the Quiros classification. This is the depth of the olfactory groove compared to the fovea ethmoidalis. So more complications happen the deeper the olfactory groove is. The more shallow the olfactory groove is, there's fewer complications in sinus surgery. That's called the Quiros classification. The L for close is the lamina papricia. Now, in a normal sinus CT, guys, this wall, the lateral nasal wall, should be exactly the same as the medial orbital wall. You can imagine if you're futzing around in here and you want to go north and you assume you're just going to go this way, right, like this. I'm going north from here. If you go north from here, you're in the orbit. So any dehiscence, whether it's chronic or acute, any dehiscence of the medial orbital wall, you want to dictate that. Again, only seen on your coronal. Okay, that's the L for close. Onodi cells. That's the other, it's the O. How do you know you have an Onodi cell and what's the point of it? Okay, here's a coronal, here's a sagittal, and here's a coronal. You should never have horizontal septations in the sphenoid sinus. Never. They should only be vertical septations. If you have a horizontal septation, guys, this is the sagittal of that Onodi cell. It's sitting on top of your posterior ethmoids. Why does anybody care? Well, I'll tell you why somebody cares. When they're in the sinus, they're assuming they have a sphenoid sinus sitting behind their posterior ethmoids, right? So they're mucking around in here, they're in the posterior ethmoids. That's why if I get here, I'm assuming I have a sphenoid sinus here. Now you're in brain because this thing overrides the posterior ethmoid. If you have a horizontal septation, you have an Onodi cell. Here are two Onodi cells, one on the left and one on the right. These are two horizontal septations. Both of these will get you in brain if you're not careful. You keep working your way back. Okay, you're hoping that you have the cushion of the sphenoid sinus there. The S, there's a few S's, by the way, but we're close. Again, these horizontal septations, you want to look at that. Sometimes you can get pneumatization of the anterior clinoid, and look where that puts the optic nerve. It's a dehiscent optic nerve. So they want all these anatomic variants dictated. I know you're like, I'm just going to leave the sinuses now. After this talk, I think I probably hurt your situation more than helped you. Probably. I think you're just going to be like, you know what? Somebody else can look at it now. But if you can do it justice, that would be great, you know? You can get very, very interesting anatomic aeration of the sphenoid sinus. But again, you want to look for these horizontal septations, okay? This is what it should normally look like. But, so I'm going to go back real quick. Guys, just for a little bit of anatomy that drives you nuts, this is V2, okay, foramen rotundum, and this is the Vidian canal down here. Sometimes you can get the Vidian nerve literally hanging out in the breeze right here in a septation. That's a dehiscent Vidian nerve. Okay? Again, Onodi cells. The other thing you want to dictate, guys, you see the septation that goes right into the carotid canal. You want to mention that because if they take this septation down, that can dissect the carotid. Okay, so you want to watch that. That's a blown up version there. Okay, so just look for these crazy areas of pneumatization. This is the optic strut, an anterior clinoid that's pneumatized, optic strut, anterior clinoid that's pneumatized. And look at the Vidian nerve kind of hanging out in the breeze here. Okay. Okay, this is it. This is the case I want you to remember from this talk, because I've seen follow-ups on this and they've been missed. Okay. Think about your sinonasal cavity, guys. There are certain sinuses that touch brain, and there are certain sinuses that don't. Your frontals touch your brain. Your ethmoids touch your brain. Your sphenoid touches your brain. The maxillaries don't, right? But this is where you get into problems. People like talking about mucus retention cysts all day in the maxillary sinus. Oh, there's a little thing there, that's mucus retention cyst. A mucus retention cyst in any sinus that touches the brain may not be a mucus retention cyst. That could easily be a meningocele. And I have seen cases like this where they have been missed and just blown off as mucus retention cysts. So when you're talking about mucus retention cysts, think about the sinuses that are touching brain before you do that. And here's some examples of this, guys. This is a case in 2019, mucus retention cysts all day, right? Was it? So this is what I start looking at. If you go back to 2015, there's a little bit of, it was much smaller. Look at 2019, what was missed. Dehiscence there. That was not a mucus retention cyst. That was a meningocele. Okay? Look at this case in 2015, chronic sinus disease all day, right? Opacification. 2018, you start getting some dehiscence there. Okay? Things grew. Now, this is what I want you to look at, guys, for sure, if you see a mucus retention cyst in your sinuses. I want you to look for other findings of intracranial hypertension. This is the diagnosis all day. Optic nerve tortuosity, partially empty sella. I look at my bone windows and I look for these tiny arachnoid granulations along the inner table. Look at these arachnoid granulations along the skull base. These are all findings of high pressure. So now I know this patient's got IIH, idiopathic intracranial hypertension, and those are not mucus retention cysts. Those are meningoceles, okay? Just remember that, if nothing else. Okay, sphenoid sinus pneumatization. Sometimes it's completely, the cellar floor is not pneumatized. Sometimes it's partially pneumatized. Sometimes the cellar floor is completely pneumatized, okay? Optic nerve anatomy, we talked about that. Sometimes it's dehiscent. That's the O, right? Anterior clinoid process. When it's pneumatized, people have called this an aneurysm on your T2, by the way. That was just air in the optic strut, anterior clinoid. Okay, so just know that that exists. Here's the E. Okay, this is the E. Okay. Your anterior ethmoid artery, guys, is right here in the medial orbital wall. Sometimes that will traverse your ethmoids. It normally goes right into the skull base. This is the only thing you're going to see on the coronal. It traverses the ethmoids. You want to mention that. This is where they bleed out. This is where they're just taking down septations during surgery, and they nick this artery, and there's no way to stop it. So dictate your anterior ethmoid artery, okay? That's often seen when you have these suprabular cells, or supraorbital cells, I should say. I think there should be a D for closed, which is dental disease, right? That's why we include the maxillary teeth on all of our sinus CTs, because you're not going to do sinus surgery when you could have just pulled a tooth. So always dictate the roots of your maxillary teeth. No self-respecting sinus surgeon will not look at the teeth first before they go in on the sinuses, okay? Structured reporting can really talk about all this stuff. And by the fact, I will give you my report. Take down my email. I will send you my template and edit it to your heart's content. If you're like, oh, that's way too much, I'm not saying that, just delete it, the parts that you don't want to dictate. I can send you my PowerScribe report, make life easy for you, okay? So in summary, guys, we just have the role of the radiologist, these critical anatomic variants and structured reporting. I hope this helps, okay? And we'll talk more about lymph nodes later.